And this is our second lecture in the series revolving around mitral stenosis. With this lecture here, we want to demonstrate visual representations of mitral stenosis. We'll cover some of the etiologies associated with mitral stenosis, and then we'll explore some of the corrective procedures that can be employed and the scoring system that determines the suitability for valvuloplasty. So commonly we see mitral stenosis as an aging process with sclerosis and fibrosis. There's the constant process of scarring and repair, which leads to calcification, which may build up on the annulus, leaflets, chordae, or papillary muscles. This process is accelerated by genetic predisposition, diet, lifestyle, and smoking. Also, abnormal calcium metabolism may accelerate this calcification process. Significant posterior mitral annulus calcification, or PMAC, is commonly seen without consequence to the valve itself. But annular calcification can be so pronounced that it moves on to the body of the leaflets and then starts to restrict their motion. And we can see that with this particular valve here. The peristernal long axis view, left ventricle here, anterior leaflet, posterior leaflet. It's all very thick and bright there, indicating a lot of calcification. And then we also see the same on the chordae, the subvalvular apparatus. In this instance here, only the leaflet tips is relatively free to move, and so we'd consider this to be moderate stenosis. So rheumatic mitral stenosis comes about from an acute illness that normally lasts for several weeks. Often recurrent bouts are actually required before valvular disease is noticed. The disease most commonly affects the mitral valve, frequently coexisting aortic valve disease. It has a characteristic zipper-like stenosis starting from the base of the commissures and working towards the middle. The leaflet tips are sclerosed and calcified along the commissure. As a result, mixed valve is often seen, with significant aortic regurgitation as well. Subvalvular involvement is seen with shortening, sclerosis and calcification, plus aggregation of the chordae. The normal thin fishing line appearance of the chordae look more like ropes. There is a characteristic leaflet motion that's seen in diastole, which differs from calcific stenosis. There is a typical doming of the leaflets, like a set of sails in diastole, and we term this hockey stick in appearance. It's more of an American ice hockey stick though, compared to the rigid fixed structures of calcification being rigid, preventing the valve from moving. And we can see this in an example here. So we've got typical mitral stenosis. In this instance, the posterior leaflet is relatively restricted, and the anterior leaflet forms this hockey stick shape. And that's because the valve itself actually wants to move, but it is tethered down at the commissures. And when we rotate to a short axis, we can actually see the zipper-like effect. So in this view here, the commissure base actually being here and here, there's been progression towards inward, creating a much smaller valve orifice. And in this instance here, we're looking at the chordae. And so instead of the thin little fishing wires that we described earlier, we've got this thick rope-like appearance of all the chordae aggregated together, fused, sclerosed, and calcified. M-mode imaging demonstrates a single leaflet motion with a box-like appearance. As we just mentioned before, the posterior leaflet is often immobile. It has less leaflet length, so when the commissure fusion occurs, there is significant leaflet motion restriction. Because the posterior leaflet is restricted, overriding of the anterior leaflet often occurs in systole. And this will then in turn lead to a posterior directed mitral regurgitation. A thickening bright line for the anterior leaflet shows an increased sclerosis and calcification on the leaflet. And we see that here with this one here. So instead of our double leaflet motion, we've just got a single opening and closing feature with the anterior leaflet. The posterior leaflets here not doing a whole lot, pretty much fixed in its position. So what would you do when we have mitral stenosis? One of the corrective procedures with balloon inflation, so valvuloplasty. It is dangerous, however, as it's not definite. The split that will actually occur will go down the commissure line. It can actually go down the body of the leaflet and lead to leaflet destruction. It has benefits, though, that it may avoid surgery or delay that might be attributed to try and get someone into surgery. It provides a benefit to the patient of doubling the orifice area and a 50% reduction in gradients is often seen. 80% of patients have a long-term relief from symptoms. Another method is valve replacement. Typically, we see biprosthetic or prosthetic valves, depending on the life expectancy of the patient, the ability of them to tolerate anticoagulants, and whether they're pregnant or not. Mortality associated with valve replacements, so surgeons look to assess stenosis with increasing frequency as disease progresses to find out when is the sweet point for them to act. Time for surgery is often indicated when the patient has significant symptoms that affect quality of life, or we start to demonstrate significant pulmonary congestion or right heart failure. In the example here, we've got a catheter wire that's actually running through the venous circulation. We actually puncture the atrial septum, so we actually acquire an ASD after this. But fortunately, the heart normally heals over, and when the ASD does close, and then the catheter wire leads over the mitral valve where we actually place the balloon and we inflate up to actually open it all out. There is the MHG score for assessment for whether valvuloplasty is something that we should consider. Basically, we give a score of 1 to 4, 1 being very mild and 4 being severe for each of the 4 categories: leaflet nobility, leaflet calcification, leaflet thickening, and subvalvular movement. If we get a score of less than or equal to 8, then it indicates that the patient is optimal for proceeding with this procedure. However, if we have severe subvalvular involvement and scores greater than 12, significant mitral regurgitation, the presence of a left atrial thrombus, then these are all indications for not proceeding with this. We can see congenital malformations that associate with mitral stenosis. They are relatively rare and come in the form of things like hyperplastic mitral annulus. The annulus is small and not well formed, and this may be associated with a hyperplastic left ventricle. We may see commissure fusion. Another thing we may see is a double orifice mitral valve. 2 small orifices open up into the ventricle. We may see shortened, thickened chordae tendineae. We may see something called a parachute mitral valve, often associated with a single propening muscle that arises at the apical level with long redundant leaflets that often prolapse back into the left atrium and systole. It is important to note that congenital malformations also have higher association with coarctation of the aorta, subaortic stenosis, and other aortic valve stenosis lesions. In this one here, we have mitral valve in short axis, and we can see this double orifice type mitral valve. And in the image on the right here, we have a parachute mitral valve. So we can see this long, redundant leaflets, and the orifice is actually down here. And in systole, the whole thing prolapses back down into the left atrium. An uncommon presentation for mitral stenosis is due to valvular obstruction. An example of this would be a left atrial myxoma. A myxoma typically forms with stalk-like attachment to the atrial septum and grows to a large pedunculating mass that moves into the mitral annulus in diastole. A typical plop sound is heard on auscultation. There is a high incidence of transient ischemic attacks, as the outer surface of the tumour itself could be friable, which has a high probability of parts breaking off to create embolic events. And here we have an example of a left atrial myxoma. So the myxoma itself here, quite large, filling most of the area inside the left atrium, attached to the atrial septum back down here. And in diastole, it moves downwards towards the ventricle and actually gets in the way of the valve opening. So we actually have limited blood flow moving into the ventricle because it's obstructing. And clearly, again, we can see this in the apical four-chamber view. So atrial septum here, so it's attached around about here, and this large mass here. And there's a very top part here, it's all very rough and irregular, and it's very mobile in its motion. A very friable edge, so a very soft type edge that's easy to break away and create thromboembolic events. So in summary, we've explored a number of pathologies associated with mitral stenosis, all which have different representations of the disease. Congenital mitral valve disease is relatively rare, but it's complicated, and there are usually other significant malformation findings that we need to assess. Corrective procedures are similar for that of aortic stenosis.